It's my fault that we didn't build in a question and answer session. I thought that would happen naturally. So we will use the breakout session. So hold your questions and you will get to ask questions to the professors individually. So my title is Observational and Database Research. And I'll try to get caught up on time a little bit. So I'm just hammering on the topic of causality. That's what we are trying to achieve. So I am talking about a few different trial designs or study designs. You heard from Dr. Sanyal about randomized controlled trial. That is the gold standard. So on this slide, you can see that internal validity is the term that we use. Is what you say the truth? Are you lying, or are you making a mistake of stating something, or are you really finding the truth? So that validity scale is better for controlled trials or a cohort study that I'm going to talk about. But in order for that to occur, you need to have some control of exposure. So trial obviously is where you control the exposure. Exposure meaning treatment or disease causative agents. Trials better that way. These are observational studies that you don't have control of exposures. So in terms of strength of causality, these studies are stronger and these studies tend to be weaker. So that's the concept that I'd like to start with. So I'm going to talk about cohort study design. Cohort study starts with a big, maybe not so big, patient population, some of whom have the exposure in question and others don't have the exposure. Okay? And then you watch those people over time, and some will develop disease and others will not develop disease. So you get these 4 different paths: exposure, disease, no exposure, no disease, and so forth. So if you take an example, that if your question is whether hepatitis B causes hepatocellular carcinoma, everybody knows that, but that knowledge was obtained by studies in the past. So here, the cohort will consist of people with exposure, meaning surface antigen positive, and some without exposure, meaning surface antigen negative. And you would follow these people over a period of time, and some will develop HCC, and others will not develop HCC. That's the cohort study. When you're done with the data collection, you will end up with this 2-by-2 table. So on the left side, you will have exposed versus unexposed, and then you will have people with disease or no disease. Easy, right? Then you have the total column that shows these are the total number of people who had exposure, surface antigen positive. Some developed cancer, others didn't. And here, people who did not have surface antigen. Some do develop HCC, even though they don't have hepatitis B. Others don't develop HCC. So at the end of the day, you can calculate the instance of disease among the exposed. Here, instance of disease among the exposed is disease A divided by A plus B, right? That's easy. Following me so far? Okay. And then instance of disease among the unexposed is the second row. C plus D is the denominator, and C is the numerator. So then you can calculate a risk ratio between that, and that gives you a risk in terms of surface antigen positivity giving rise to hepatocellular carcinoma. So that's what you want to get at the end of the day when you do a cohort study. Let's look at an example. This was a New England Journal paper from Taiwan, a cohort of 12,000 men from 7 townships in Taiwan, long time ago. And they followed them for 8 years. And they came up with this 2x2 table that we just discussed. So exposed, 2,300 patients. Unexposed, 9,500 people. So you calculate the incidence among the exposed was this, that divided by that. And incidence among the negative people was that divided by that. So when you do the bottom line calculation of risk ratio, they came up with 11.7. An interpretation of that is hepatitis B increases the risk of liver cancer by about 12 times. It makes sense? So hang on to that 12 times in your brain. Okay. But I'm not in Taiwan, you will say, and I don't have 8 years to follow these patients. I want to do this research today. So how do I do that? And that's when existing database comes in handy. And Dr. Freed talked about his own database, and if you ask him nicely, he may share his data. But there are data you can get today from different sources. And these are different kinds of data that you can get. You can talk about hospital discharges, you can talk about population mortality, health behavior, cancer statistics, transplant, and so forth. It depends on where you look. And this is a paper that one of our faculty published at Stanford, collating all the available data sets that you can acquire. And this is only an example of data sets you can purchase or you can download. So UNOS database or OPTN database, you've heard about that, right? It's a famous liver transplant database. I actually don't know whether you can request data from Mexico to UNOS. I apologize, I could have done that homework. But for most US people, you can write to UNOS and they ask you, you need to sign this agreement. You sign and they send you a CD, free. Other systems, like some of the CDC data sets that are shown here, BRFSS, NHANES, NHMCS, and so forth, these are all online available. You can download these data and start your research today. There are more examples. MEPS is also a database that you can download. SEER is a cancer database you can download. The other things may require some payment, but they are not that expensive. They are, for example, this healthcare utilization project, I think their data are like $200. And you get millions of people's data, very rich. There are more expensive data sets, but we don't necessarily need to use or spend thousands of dollars to get those data sets. Oops. So I'm going to give you an example how an NHANES data, which is totally free, be used for publication. This is a paper that we did. We downloaded an NHANES data set. So NHANES is a population survey of people's health in the US, and you can get it for free. The beauty of NHANES 3 data is that they have a baseline data set, how people looked like at the beginning, and then they have a mortality data set. They follow these patients and determine who died for what reason. So that's the database we used. So these were all adult individuals. Between 1988 and 1994, they were surveyed and examined. That's when we had the baseline data. They happened to have an ultrasound examination, and that allowed steatosis assessment of the liver. And these people were followed forward through 2006 for mortality. So we defined NAFLD based on ultrasound, and then we also excluded, based on laboratory data, alcoholic, viral hepatitis, iron overload, and so forth. So that's how we define fatty liver. And then we used a non-invasive indicator of fibrosis called NFS, NAFLD Fibrosis Score, and score people who had minimal chance of advanced fibrosis, intermediate, and high chance of having advanced fibrosis. And this is what we found, that this is the entire US population. 66% did not have fatty liver, but as many as 34% of the US population as of 1990 had fatty liver disease. That's 44 million Americans with fatty liver disease. And then when we applied NFS, the non-invasive score, we found that 1.8 million people, or 1% of that population, had advanced fibrosis. So that's a very large number. So this is the kind of data that gets quoted a lot when people write papers on fatty liver disease in the US. This is one of the papers that quote. And for that, I invested $0, but I worked on it for a few weeks. But when it goes, as far as it goes to do research, that's pretty minimal investment, and you can get some mileage out of that kind of effort. So this is the meat of the paper. When we follow these patients with a follow-up data set, 15-year follow-up, Kaplan-Meier survival was 84% over a 15-year period. The mortality cause was cardiovascular mostly, 9.5%, malignancy 5%. Liver mortality, these are fatty liver patients, was only 0.4%. So we ran the Cox model and looked at all NAFLD patients and what the proportion of, what the risk of NAFLD associated with mortality, and then nothing really was important. None of this was statistically significant, that having fat on the ultrasound had no impact on mortality. But when we looked at people with advanced fibrosis, then something significant showed up. So for those of you who, I'm sure you know this, when you look at the confidence interval, if that includes 1 in between, that is not statistically significant. So all of these has 1 in their range, so none of these is significant. But for example, cardiovascular, the hazard ratio was 3.2, and the confidence interval, both numbers are greater than 1. So they are statistically significantly increased cardiovascular. So if you have NAFLD with advanced fibrosis, the risk of death by cardiovascular cause goes by about 3-fold. So that's important. But when you look at the liver disease, there is still no signal. There is no statistically significant increase in mortality from liver disease. So this sort of disappoints the NAFLD enthusiasts who think that NAFLD is a very, very important public health threat. These kinds of data show that the larger picture, that it may not be as important, although there are many criticisms about that kind of statement because it was relatively short period of time and fatty liver is defined arbitrarily and so forth. But nonetheless, I got a paper out of this work. So I hope that it's an encouragement for you to look into these things. I'll skip this slide. So I'm going to talk about case control study. Okay. So example that I'm going to use for case control study is whether alcohol causes hepatocellular carcinoma. Okay? It's a legitimate question. I'm going to ask you a question. Here, who are the controls? Are the controls who don't drink? Who think that controls are people who don't drink? Some of you. The controls here are people without HCC. Who are the controls? Controls, HCC, non-HCC are the control group? Okay. If you remember anything, remember that. The right answer is people without HCC are the controls. So this is how it goes. For the case control study, you don't start on the left side. You don't have, sorry, I'm doing the Mauricio thing. You don't necessarily have the exposure information at the beginning of the study. You're doing the study today. where you have people with disease and people without disease. Here, the cases are people with disease, controls are people without disease. And then your study is about whether the cases and controls had exposure in the past. So cohort studies takes a long time, large number of people. Case control studies is more economical and more efficient. You start with patients with disease and you get controls who don't have disease, and then you ask about or you discover what their exposure history is. So this is the setup. You have people with cancer, people without cancer, and then you're going to find out whether they drank in the past or not. So that's case control study, different than cohort study. So here, you get the same 2 by 2, but you're starting with disease versus no disease. You're looking at this, looking at this table, sorry. Looking at this, I'm not gonna use this. Looking at this table this way, vertically, disease, no disease, and then you correlate with exposure. So here, unlike the cohort study, the total column has no meaning because you don't know the total population who had exposure versus not exposure. Here, therefore, you can calculate the risk as we did with cohort study. Here, you can calculate what's called odds ratio, which is A times D divided by B times C. The meaning of odds ratio is very similar to that of relative risk. So that's the strength of case cohort study. Without having to expend all the money and spend the time, you can get the roughly right answer by doing this type of study. So an example for this is Jorge Marrero's study, who identified 70 people in their clinic with HCC, and in the same clinic, they identified 70 people without HCC. So these are cases and controls. And then they went back and asked about their alcohol use history. And this is a table that they came up with, 2 by 2. And again, the total column has no meaning because you don't have the baseline population, but you can calculate odds ratios, and they came up with 3.7. Meaning that drinking is associated with 4-fold elevation of risk for HCC. Whether that is the right answer or not, we don't know, but that is what they came up with. So in the next slide, I'm going to demonstrate how the case control studies can get the right answer. So remember the Taiwan study with cohort study. If they chose to do a case control study today, and went back to their clinic and picked 100 cases, again, HCC, and 100 controls, no HCC. If the selection is random, they would find this. So this is the same table that I showed you a few minutes ago, right? So of their controls, 19% did have surface antigen, 81% did not. So if they did the study correctly, out of the controls, 100 people, they should have 19 people with surface antigen and without in the rest of the people. Do you follow? So if the cases and controls are picked sort of a random with regard to the exposure, then they would have come up with a 2 by 2 table like this. And the point that I'm trying to make is, if you came up with this table, the odds ratio that you will calculate will be 12. Okay? And compare that to the cohort studies relative risk 11.7. So the point is, if you do the case control study correctly, you get the right answer that you would get from the cohort study. So case control study is easier to do, but you need to think more carefully whether your controls are selected correctly. So case control study will give the right answer only if selection of cases and controls are random with regard to exposure. So remember that. A counter example is this bogus case that I'm going to show you. For a case control study to be valid, we made this point, the selection process is important. So let's say we want to do another study looking at HCC and alcohol. And you pick cases in the liver clinic for HCC, and you say, I'm going to go to the addiction clinic to get controls. These are people without necessarily liver disease. Then you will see that a lot of people here, everybody will be drinking, whereas HCC cases not necessarily from alcohol will have random chance of drinking, and you do an odds ratio and you get completely wrong answer. This odds ratio will say alcohol is less than only 10% associated with HCC. So I don't know if you're following this, but the point is cases and controls need to come from a population that you would have conducted the core study in. So be very careful when you do a case control study to get the right answer. So this is my last slide, take-home points. Epidemiology is a study of causation. So think about that. The two common observational study designs, a cohort study and case control study. Cohort study is considered the gold standard. You get the absolute and relative risks, but it is long and expensive to do. Case control studies are the opposite of that. It is very commonly used because it's not long or expensive, doesn't necessarily need to be. It gives you an odds ratio that is roughly the same answer as relative risk. But again, you need to be careful with selection of cases and controls. I talked about database research. Database research is attractive because, as I showed you, there are many data sets that you can acquire without having to collect your own data. Availability is important, and many of those databases are generalizable to the population that you're studying. It is very good to create preliminary data so you can go to a funding agency and say, I've done this, so I'm going to go collect my own data to answer further questions that I have. However, it has some cons. The database is what the database has. So you don't know if you have a question that is not addressed in the database as a variable, then obviously you cannot do the research. The data were collected by someone else, so you trust them to have accurate and valid data, but you don't have a guarantee for that. And as you may have felt, in order for you to do a database research, you need to have substantial statistical knowledge. So you need to learn that, or you need to work with somebody who can help you with that. So I hope that is useful for you. I look forward to more exchange of ideas and questions at the breakout session. And I'm going to keep going to be caught on time. So next speaker is our dear president, Professor Sokol at University of Colorado. He and the next speaker, Oliveira, will talk about sort of a special population to do research, and Dr. Sokol will address pediatric population. There's specific features of that. Thank you. Okay.